Good morning, everyone. Today, the topic of my paper for CT bus is CT Spectrum of Meckels diverticulum. This is a case series highlighting complications in inversion, gangrene, torsion, and bleeding. My name is Dr. Mahim Singhal, and my co-author is Dr. Gitanjali Sethupathi from Kalinga Institute of Medical Sciences, Bhubaneswar. Aims and objectives. Aim is to highlight the diverse clinical and imaging manifestation of Meckel's diverticulum through a series of surgically confirmed cases and to emphasize the importance of multimodality radiological evaluation in its timely diagnosis and management. These are my objectives. Introduction. Meckel's diverticulum is the most common congenital anomaly of the gastrointestinal tract resulting from persistence of the vitelline duct. It is seen in 2% of the population with a male predominance of 2:1. The classic rule of twos occurs in 2% of people located approximately 2 feet from the ileocecal valve to approximately 2 inches long, symptomatic in 2% of cases and most often presents before 2 years of age. The clinical spectrum is wide. It includes bleeding usually in children due to ectopic gastric mucosa, obstruction from intussusception, inversion, volvulus or Little's hernia, diverticulitis or gangrene which can mimic appendicitis, torsion which is rare but it is a surgical emergency. Because symptoms mimic other acute abdominal conditions, imaging plays a central role in timely diagnosis. First case. This is a case of inverted Meckel's diverticulum with intraluminal lipoma causing intussusception. A 30-year-old female presented with 3 days of central abdominal pain, vomiting and loose stools. She reported 2 prior self-limited episodes of similar pain. On examination, mild abdominal distension, tenderness without peritonitis was seen. Labs showed mild leukocytosis. CT scan was done and distal ileal intussusception with a classic target sign was seen. At the lead point, a fat density lesion was seen with a blind ending tubular structure arising from the antimesenteric border of ileum, representing an inverted Meckel's diverticulum containing a lipoma. Proximal small bowel was dilated. Laparoscopic resection of a 10 centimeter ileal segment including the diverticulum was done. Histopathologically confirmed lipoma within inverted Meckel's. Outcome was uneventful. The patient was discharged on day 5. So these are the CT pictures. The distal ileal intussusception with the classic target sign seen. At the lead point, a fat density lesion was seen with a blind ending tubular structure uh, arising from the antimesenteric border of ileum, representing an inverted Meckel's diverticulum containing a lipoma. Here, proximal small bowel was dilated. Case 2. This is a case of gangrenous Meckel's diverticulum mimicking acute appendicitis. A 40-year-old female presented with acute right iliac fossa pain, fever and vomiting. Clinical exam showed guarding, rebound tenderness over McBurney's point. Lab showed leukocytosis with neutrophilia, elevated CRP. Initial clinical diagnosis was acute appendicitis. But the CT findings showed normal appendix, dilated distal ileal loops with wall thickening. Blind ending tubular structure on the antimesenteric border showed non-enhancing necrotic wall with peridiverticular fat stranding and free fluid, consistent with gangrenous Meckel's diverticulum. At laparotomy, gangrenous Meckel's diverticulum approximately 90 cm from the ileocecal wall was seen. Resection with ileo-ileal anastomosis was performed. Histopathology showed transmural necrosis. Final diagnosis was gangrenous Meckel's diverticulum forming a band along small bowel, and outcome the patient recovered post-surgery without any complications. So in this CT image, we see dilated distal ileal loops with the wall thickening. Blind ending tubular structure on the antimesenteric border showed non-enhancing necrotic wall with the peridiverticular fat stranding and free fluid consistent with gangrenous Meckel's diverticulum. Case 3. Giant Meckel's diverticulum with torsion and ischemia. A 52-year-old male presented with severe acute abdominal pain, distension and bilious vomiting. Examination showed diffuse tenderness, absent bowel sounds, early peritonitis. Lab showed leukocytosis and metabolic acidosis. USG findings were lump in the right iliac fossa, but appendix at the same time was also visualized and was found out to be normal. CT findings. Large blind ending diverticulum arising from distal ileum. Wall sign of mesenteric vessels at the diverticular base suggesting torsion was seen. Poor wall enhancement indicated ischemia. Diagnostic laparoscopy confirmed torsion of a giant Meckels diverticulum with ischemic necrosis. Segmental small bowel resection with anastomosis was performed. Patient had a 1 week ICU stay and recovered uneventfully. In this USG, we see a lump in the right iliac fossa here, and CT scan was done subsequently, which showed a large blind ending diverticulum arising from distal ileum. Wall sign of mesenteric vessels is seen at the diverticular base, suggesting a torsion. Case 4 is of bleeding Meckels diverticulum in a pediatric patient, 1 year, 5-month-old baby, intermittent rectal bleeding for 11 months, occasional with blood clots and melena, no associated fever, pain and diarrhea, constipation or urinary complaints. 2 prior admissions for similar complaints were there. Extensive prior workup was done, which was normal. Previously, Meckel scan was also done, which was negative. Examination shows child was pale and anemic at presentation, otherwise unremarkable exam. Imaging showed imaging CCT was done, which showed a blind ending tubular structure, approximate 1.8 into 8 centimeter into 8 mm, arising from mid ileum, seen at midline in mesentery. Features are suggestive of a diverticulum likely arising from the mid ileum. No obstruction, perforation, or active contrast extravasation was there. Exploratory laparotomy confirmed Meckel's diverticulum in distal ileum. Diverticulectomy was performed. Histopath confirmed ectopic gastric mucosa, which was causing bleeding. Outcome was uneventful recovery. Rectal bleeding resolved post-operatively. So these are the images of this CT scan of the child. A blind ending tubular structure is arising from the mid ileum, seen at the midline in the mesentery. Features suggestive of diverticulum. Discussion. Meckel's diverticulum, a remnant of the vitelline duct, is seen in 2% of the population and often follows the rule of twos. While many remain asymptomatic, presentations vary with age. Painless bleeding in children from ectopic gastric mucosa and obstruction or inflammation in adults due to inversion, intussusception, torsion or diverticulitis. Imaging is central but challenging. CT is most useful in adults with acute abdomen, revealing a blind ending ileal pouch with thickening, fat stranding or secondary signs such as the target or wall sign. Technetium 99 biochemical scan is test of choice in children with bleeding, but sensitivity is imperfect. Our case demonstrated a false negative scan, with CT ultimately showing the diverticulum confirmed at surgery. This emphasizes the value of multimodality imaging when suspicion remains high. Surgery remains the definitive treatment with diverticulectomy or segmental resection depending on the morphology and complications. Outcomes are excellent when diagnosis is timely. Conclusion. Meckel's diverticulum presents with varied complications ranging from bleeding to obstructed and torsion. CT is vital for adult acute presentation, while the Meckel scan remains the first line test for pediatric bleeding. However, false negatives can occur and complementary imaging is essential. A high index of suspicion, systematic review of the distal ileum and multimodality imaging together ensure early diagnosis and successful surgical management.